sometimes write things abbreviated just brevity. So next, after assessment comes planning. So optimal pulmonary function, adhere to the therapeutic regimen, measures to prevent spread of disease. So good diagnosis here. So we think airway clearance, gas exchange, altered nutrition, because remember we talked about that weight loss, unexplained, unintended weight loss, alteration comfort from that pleuritic chest pain, and the problems coping for being in isolation and long-term therapy. So promote airway clearance, easy peasy. We talked about how they have orthopnea, so what are they gonna have to do? Yeah, it'll probably be high volume to breathe. What else? If they need supplemental oxygen, what do we do to the oxygen?
Humidified.
Yeah, humidified oxygen, because oxygen is very dry. It's gonna cause some bleeding, more bleeding to your nose. It's extremely dry. So for years I said that, right? Like oxygen dry, until I had this whole big crack my head open episode with pneumonia. It feels like too light or big lighters in your nose. Like it's very dry. It's extremely uncomfortable. I kept taking it out, of course. And they thought it was hypoxic. I'm like, no, I just got busted if you take me, because I would take it out when you left. So, and again, so that sitting in the high Fowlers, supplemental oxygen is both gonna help with airway clearance and the gas exchange. Obviously, you should be telling them to stop smoking. Gonna help outpatient. So comfort for oh, go ahead.
Sorry, what about
No,
the
don't be
sinus barometer?
And except, yeah, you can never go wrong with that one.
Yeah.
That can help with, that,
Gas exchange or clearance?
really both of them, really, yeah. Yeah. And then so teaching for incentive barometer is gonna be what? Don't answer, Captain, we just went over it, so you can answer. Incentive barometer teaching is, it's a classic answer, it's gonna be at least 10 repetitions every hour while they're awake. And remember, they're inhaling on this barometer. So for comfort, so unfortunately for pleuritic chest pain, because it is, oh, what? Where's the comfort on yours? It's on your printout ones? It's not? I added that in and printed it out. So just add in to promote comfort, please, I'm so sorry. Because the pleuritic chest pain can be an issue. So a lot of times here is really gonna be an NSAID that's a little more helpful. So like an ibuprofen, naproxen, coupled with an opioid perhaps. But again, these days of the opioid crisis, we try and decrease opioid use. And plus for pleuritic chest pain, because there's a whole inflammation component, that's how the anti-inflammatory is really more helpful. So start with that. And then even these things now, like, because you just learned about local anesthesia, doing topical lidocaine. So that's very common now, to do a topical lidocaine patch. So that's something else could help with promoting comfort. Because think, why do we want them to be comfortable? One, it's ethically good. We don't want people to be suffering, but why else?
You can put topical on like their chest and it will get down to their pleural cavity? Oh?
Because you want their vitals to stabilize, you don't want them to have like a high heart rate or high respiratory because they're
True, and think if I, what? Yeah, you don't want to freak out, right? And right, and think, if it hurts when I take a deep, if it hurts when I take a deep breath, am I gonna be taking deep breaths? No, I'm not gonna be doing that. I'm not gonna use this barometer because it hurts. So if I get my pain under better control, then it's gonna help with the first two also. So adherence to medication regimen, so we're gonna talk extensively about the medicines. Some on your, some on this one.
Next one.
What was the other,
Oh, I broke them up.
what was the other, comfort, is it like?
So, I mean, certainly, and I'm so sorry, I didn't even say non-pharmacologic things, like, whatever the person's position of comfort is, we wanna do that. You can always do things like distraction and music, I don't mean to be so just clinical, but frankly, if you're having chlorinated chest pain, you need some medicine, like, you know, listening to Earth, Wind, and Fire might not cut it. So that's why I said, you know, we need some, 2019, we need some medication, so. We're talking about, always go for that non-pharmacologic answer though, like,
Right, but like, you wouldn't use like an opioid because you have respiratory depression, right? So.
well, but you might need a little bit of an opioid, yeah, that's why I'm saying, like, do the topical, like, they do the lidocaine patches more often now, and the NSAIDs, and then if it's really bad, an opioid, but. So here's the medication regimen, really, we're gonna talk extensively about that. The thing that you can write down right now, though, is called, direct observed therapy, DOT. And it's just a community-based program where they really have a visiting nurse come out and see them to make sure they're taking the medication.
What was it for direct?
Direct observed therapy. Oh, no, I'm happy to answer it. Direct observed therapy, DOT. So that's really helping with their adherence to the medication regimen. And then, I didn't mean to look up before, I don't know, and I'm not trying to be smart when I say this, I don't know if there's a tuberculosis support group, like I would think in this day and age, maybe there is, like somewhere they could like, you know, do it online and talk to people. But that direct observed therapy is supposed to be helping with that too, because
It's just people to come out and make sure you take your med.
make sure you're taking your medication, making sure you're getting your labs checked up, because some of the medications are, you know, need to have laboratory work followed up, make sure you're doing your cultures. But yeah, like I said, hopefully there'll be a support group for you. So, medicines, same old things again. We want to make it non-communicable to others, reduce the symptoms for the patient, and get them to be cured in the shortest time possible. So, based on the medications they take, they're gonna be prescribed, plus their own comorbidities, so what's going on with the patient, that's what's gonna guide what labs they need. So basically, we already said everybody's getting what? They're definitely getting the sputum culture, you know, the sputum to diagnose them. And though I didn't write it, they're generally gonna get, what else? The CBC, to check what their white count is. So what else is in the CBC? White blood cell count, hemoglobin, hematocrit, and platelets. Part of the CBC. Though I didn't write it, they also are gonna check their whole electrolyte panel. The whole sodium, potassium, chloride, CO2, BUN creatinine, and glucose.
Can I ask you a question that is kind of related to the CDC? Do they do like with and without differential, and what does that mean?
So, no, great question. So typically these days, first, your first question. When it says CBC with differential, differential is checking the different percentages of your white blood cell count. So it checks the granulocytes, neutrophils,
Okay.
eosinophils, all those things. Typically, unless it's specifically ordered like that, the lab doesn't do that. One, because it costs more money, and you know, you don't be overcharging the person. But if your white blood count comes back abnormal, meaning too high or too low, it automatically makes the lab do that. So, you know, you can order a CBC with differential, but even if you don't order it, if it comes back abnormal, they'll automatically do it. So the differential is when we're looking to see, you know, for different reasons, whether it's an oncology patient or, you know, again, we're checking to see if they have whatever is wrong with their differential, that's when you do order it. That's a great question. So in addition to this, we're, you know, doing the CBC, doing the electrolyte panel, whatever it's called where you're working. We want different slang for that, but it's, it's empty. So save 7. And now, so renal is gonna be, we already said B1 and creatinine, so those are our 2 old favorites. So now in 200, we're gonna step it up to creatinine clearance. So creatinine clearance, nothing no normal for right now, but creatinine clearance is a test that's more specific, and it kind of adjusts for one's age and race. So sometimes they'll check that one out. So again, creatinine clearance adjusts for one's age and race. And if somebody really has renal problems, what are we gonna check? Kelsey said it one time already. There's other 3 electrolytes. Yeah, calcium, magnesium, and phosphorus. You're so smart. And then, so liver enzymes, so, your book just says LFTs, that is not good enough for the Evening Weekend program. So you're gonna know that they're transaminases. So saying the whole words is, I don't want you to get overwhelmed, but AST, so it's aspirate transaminase, and ALT is alanine transaminase. That's what we just say, AST and ALT. So those 2 transaminases are more specific to hepatic cells, because they can be elevated for different things, but those 2 are specific to liver injury. And then there's direct bilirubin. So again, direct bilirubin gets elevated with liver injury. There's other things that can make it change. So there's more LFTs. Those are just a little starter pack. But just ALT, AST, direct bilirubin. There's other things that can be abnormal. And honestly, for right now, you don't have to know, I'm saying it, hopefully people are recording me. You don't have to know the normal ranges for this, but you have to know AST, ALT, direct bilirubin. Those are part of the LFTs, of an LFT panel. So vision examination, because you can get visual changes, you can get color blindness from some of the anti-tubercular medications. You can also get, oh, I'm messing up. Not uveitis, but it'll come to me in a second. I have a little gap. Another eye disorder. But so they're gonna get a vision screening exam, and they're gonna get a hearing test, or should be. In a perfect world, they're gonna get all this. So here we go. So the drugs, anti-tubercular agents, so again, I know the one slide said 9 to 12 months, this was like 6 to 12 months. It's gonna be at least a year that they're on the medications. At least you just think of it that way. So then this initial continuation phase, I honestly not gonna, there won't be questions about this. There's just 2 phases of therapy, classic and teaching about tuberculosis medications. There really won't be questions on this, I promise. There will be questions on this though, so for drug resistance, so if no drug resistance is demonstrated in cultures in the first 2 months, then they'll continue on with they'll have more therapy with these 2 drugs. This is really, don't have to study hard on this one, because really what's important is that we're gonna have infectious disease on the case by now. And on page 453.
So for the drug therapy, you were saying it's really important, and you said it's not important.
So let me backtrack. Don't worry about this initial continuation.
Okay.
That's one thing I said.
Before the drug resistance, so if they don't have anything, any resistance in the cultures for 2 months.
Yeah, they're gonna continue with these drugs. Okay, that's more nice to know information.
Oh.
But it's a thin line through. It's not inaccurate, but Something's gotta give. We can't, we can't get this intent on everything. It's nice to dig me, read between the lines. I can't delete stuff that's not accurate, but it's a little intense here. Here's one, though this is one to start. This is an important one. Prophylaxis. Somebody's on prophylactic treatment for TB. So what's prophylactic mean? No one say condom. Prophylaxis means I'm preventing me from getting TB. I've had an exposure. I work in the prison system. I'm now taking INH. So INH, isoniazid, is a big TB drug. So for prophylactic treatment, that's when you're just going to be taking one drug, generally INH, for at least a year. So again, this is to prevent active disease, but still consulting the ID practitioners, because the drugs are so resistant these days. Could be something different, but classically, this is the one drug you're on. But if there's ever a question asking about if they're on one drug, that would just be for prophylaxis. Not that I actually have TB. It's not sufficient. Get it? So that's the important one about this one. Oh, so on that page 453 in your book, it talks about different drug regimens. Don't, I hate to sound not academic, but there won't be specific questions about which drug combination a patient could be on. They're gonna be on a combination of these 4 drugs we're about to talk about. That's what we can say. And here's the drugs. So in some combination, they're gonna be on these drugs. Whether it's that initial phase, continuation phase, lovely to know about in general, but you get into it. So INH, isoniazid, rifampin, PZA, ethambutol, and vitamin B6 is important because vitamin B6 paroxetine prevents INH-associated peripheral neuropathy. So all that's things you're saying, you can get numbness and tingling from being on INH. So you want to make sure that the person has adequate B6.
So should we know those 4? I mean, do we have to make like drug templates and stuff, or?
Well, but I know that the information contained in the PowerPoint is sufficient. I swear. You don't have to make separate templates. Was that on the template list? Were these drugs on the template list?
No.
No, I'm not trying to throw anybody over the bus, but me and Ms. Austin and I did not make up these drug templates. But I have to tell you, these are, when there's questions about TB, you'll be asking about these drugs. So, sorry. But you don't have to don't make up separate templates. And that's just because these are not drugs you're gonna see in the hospital. Like, we're not giving TB drugs in the hospital, frankly. That's probably why they didn't have any drug templates on them. But when you have questions about TB, ATI, and ultimately NCLEX-wise, it's gonna be about these. So, in summary, for our exam, yes, you have to know about them for the exam on this unit. But just worry about the stuff that I gave you in the PowerPoint. Dig me? Some more time, so B6, so that means what? Start B6, because you gotta think of, sure, I can take a supplement, you have to think of dietary sources for B6, which is gonna be what our usual fave, enriched grains, right, the green leafy vegetables. Always, never go wrong with those two. And then where it says importance of combination medications, so some medications are already in a combination pill. So just like over-the-counter cold medications comes in combination agents, they're already in a combination just to increase compliance. So one more time, this is a big one. I'm formulating a test question right now. Reason why you have people take combination medications in general, is just to increase compliance. I'm more likely to take it if it's already in one pill than if I have to take 3 different pills. So, combination medication, again, the reason is to increase compliance or adherence, nicer term we could use. So, again, multi-drug resistance. So when something is multi-drug resistant, they're gonna need, other drugs besides these classic 4 drugs. So one more time, these are those first 4 are the classic 4 anti-tuberculosis drugs. B6 is not an anti-tuberculosis drug, it's just important because of the INH. But if if you have multi-drug resistance, just like it says, you're gonna need a different agent. So then you go into the second line, and blah, blah, blah about extensively drug resistant. That's lovely. Don't have to know that specifically. What you have to know is, if I have something that's really drug resistant, I could be on the drugs potentially for 2 years, which I've said multiple times. So resistant drugs means I'm gonna be on it for longer than a year. So, as a person's on them, because you're gonna be still gonna be getting cultures. So effective treatment means now they start to get negative cultures within 2 to 3 months of therapy. So the cultures are negative means I can stop taking the medications, right? No, I'm not stopping the medications because I have negative cultures. Once I have positive cultures in HPV, I have it, means I'm gonna be on the drugs for at least 1 to 2 years. So could hopefully they're not infectious to others by then. But if the cultures are positive, so then they could be drug resistant. So meaning they're gonna have the medications they change. They're gonna be changing the combination of medications they use. So now I'm having a culture and sensitivity report. So culture and sensitivity report means, now should be live, don't answer. So something that means what? I know the organism that I'm dealing with, but now I want to see whether it's sensitive to the drug I'm on or not. So the report will come back I or S, meaning it's sensitive to it or it's not, or it's resistant. I guess it says I, R, or S. So they just inoculate a little plate or a little slide or whatever, and if it's has a zone of death of the bacteria around it, then you know that it's still effective. If it's resistant, then you know they need to change the drug profile. So this is why they're still getting cultures throughout the therapy. So I'm still telling that same thing about they're getting it early morning, they're rinsing out their mouth first. And then they're gonna add other medications if the culture is still positive. So hepatotoxicity and neurotoxicity with INH. So now we're talking about INH, isoniazid. So already said, checking those AST, ALT, direct bilirubin. What are other signs of, it's gonna come up, I'm sorry, I'm jumping the gun. So I'm looking for signs of liver toxicity. It's gonna be what? Jaundiced skin, so yellow cancer skin, jaundiced sclera, icteric sclera. Could have also itching to the skin. And neurotoxicity mostly is numbness and tingling to the fingers and toes. So supplemental B6 vitamin, or make sure you have good dietary sources, because that's the test question generally. And we already said dark green leafies, grains, some meats. Avoiding alcohol. So avoid means they shouldn't be drinking any, but hopefully they can do that. What would be a drug for alcohol withdrawal syndrome?
For
No, just,
Well, test wise, it's the chloride dipoxide, lithium, but real life is generally CRF, but it's some benzodiazepine. The chloride dipoxide is the lithium. But we wanna avoid alcohol because alcohol is what? Is hepatotoxic itself. And so, not to be smart, we gotta tell people, alcohol, that means beer, beer's alcohol. Because they don't think you will. And then any changes in vision, so blurred vision, double vision. What else should they avoid? There's those darn tyramine foods again. So, because tyramine can increase toxicity of the drug. So our tyramine foods are gonna be aged cheese, red wine, organ meats, chocolate. Let's listen for a minute.
What's the other thing?
Okay. Something about little boy control. Okay, so neuro effects one more time. It's gonna be silly, like headache, but more headache, so it's, that's with everything. But the numbness and tingling. Cardiovascular wise, gonna have rapid heartbeat or pounding heartbeat. Also feeling lightheaded. And skin could have jaundice, but also could have redness or itching. Medical term for itching is gonna be pruritus, right? So INH, how I remember INH is, I know this sounds very rudimentary, but just the N, INH, so numbness. INH numbness, got the hepatotoxicity too, but it's kind of, big thing is numbness, got the foods there, no alcohol. And no alcohol is not a big stretch because generally think, with most anti-infective agents, means antibiotics, you're not drinking alcohol. You're gonna tell people that generally anyway. So next one, rifampin. So same thing, hepatotoxicity, we already talked about that. Anemia, so how are we gonna know somebody's anemic? Checking their CBC for the hemoglobin and hematocrit, but we're gonna know how else they're anemic, because they have what? Yeah, fatigue, could progress to being short of breath because I don't have enough hemoglobin carrying my blood around. Pallor, beautiful. So thrombocytopenia, that's gonna be revealed on their CBC also, and so that is gonna, thrombocytopenic means that I have low platelets, so therefore, what's normal platelets? Gotta go back to Scott again, Scott and Tim owe me a response, so Scott, thrombocytopenia. Normal platelets are?
I have no idea, I've never known.
It's high number. Yeah. What'd you say there, Brittany?
100,000 to 450,000.
Yeah, beautiful, yeah, 150,000 or 400 to 400,000, way up there. But if I don't have that number, because I don't have a lab machine at my house, how about if somebody's thrombocytopenic? They don't have enough platelets because they have bruising, bleeding gums. Cut myself, won't stop bleeding. And here's a big one, weird one with rifampin, that their urine and tears, saliva can turn red orange. Dun dun dun. Right.